My name is Adrian McKenzie. I work at a center whose title is much too long, and we're going to work on that at Dalhousie University. I'm presenting on behalf of a broader research team, which I'll describe in just a moment. So what I'm going to speak to you about is, first of all, explaining sort of where this piece of research, where this project came from, what it is that we set out to try to do, who we worked with, what we did specifically, what we found, what we think are some of the policy implications or policy options that arise from what we found, some of the limitations that we encountered in the work, the conclusions that we drew, and then I'll be happy to take your comments and questions on all of that. So I'm sure, given this audience, I don't need to say very much about the importance of adequate or effective planning for meeting the needs of our senior population here in Canada. It's a priority of all governments of all levels in managing the resources that go to meeting their various healthcare needs. Those resources are limited, and of course we need to make as efficient and effective use of those as possible. So that's where this type of approach comes in. So there seems to be some consensus, and we probably, I'm sure there's different views on that here, that there seems to be consensus that we can do a better job than we currently are, or we have been doing, on using the resources that we've got to meet the needs of our senior populations in particular in Canada. And what this project was about was implementing what we call a service-based approach to planning specifically for health human resources, or human resources for health, depending on which country you come from. And that approach is very much a back to basics type of approach, where I'll describe in a moment. So we wanted to specifically, first, more broadly, implement that approach or demonstrate its application in two jurisdictions in Canada, here in Nova Scotia, but also in Nunavut, one of our northern territories. So two very different settings and populations within the same country. We wanted to identify the leading health conditions for those populations. We wanted to identify the specific services required to meet the needs of seniors in those jurisdictions in home and long-term care, to identify gaps in those services with services in terms of how often they're needed versus how often they can be provided, and identify potential policy options for addressing those gaps. So I'm with the WHO PAHO Collaborating Center on Health Workforce Planning Research, very long time, at Dalhousie University. We're fortunate to partner with the Department of Health and Wellness here in Nova Scotia, as well as the Nunavut Department of Social Services, Health and Social Services. And this research was funded through a contribution agreement from Health Canada. So as I said, one member of a large team at Dalhousie. My boss, Gail Talbot Murphy, who I think is known to many of you. Other researchers like Ken Rockwood, I'm sure are known folks to many people here. We had steering committees in both jurisdictions, Nova Scotia and Nunavut. We're fortunate to have as partners a number of different organizations, including Order of Nurses, these departments of health, as I mentioned, different colleges. So we had a whole group of that were able to get this done. This is a photo, and I don't know if it doesn't come out all that clearly. We're out there. That is a shot of Gail and myself and Margaret Hickey, who's another member of our team, on the shores of Frobisher Bay. You can see the sunset, which is there at that time of year, about 1:40 in the afternoon. So this to say, not just because I like the photo, but also just illustrating a prompt for some of the differences between those two populations. Even Canadian jurisdictions, the geography, the population, the culture, a lot of differences in the two settings. So that was part of the purpose in choosing those two sites, is to see how the approach could be implemented in different ways to reflect those differences. So what did we do? Well, we started, as I said, is trying to get back to basics. So we want to try to figure out ways to plan better for the seniors in these two jurisdictions. So we started with, well, what is it that they need? What are the health conditions that are most pressing for them in these two jurisdictions? So we started with reviewing administrative data that was available more easily in Nova Scotia for a number of reasons. But of course, that doesn't give you the whole picture. So we were also out speaking with clinicians, people in government, and community representatives from both jurisdictions to see, well, this is what's coming out of the records and the hard numbers. Do these jive with what you're seeing on a day-to-day basis? We found in some cases that they didn't, and we made some adjustments or some additions to our list of pressing health conditions accordingly, but and then we went from there to, so once we had a list of the major health conditions that affected both jurisdictions, we set about trying to identify and make a great big list of all of the different healthcare services that seniors in home and long-term care might be required or might need to address those conditions. That was that was an interesting task. So we ended up with quite a lengthy list, which I'll get to in a moment. But we started with what we could find in terms of practice protocols and things in the public literature. But then we ran it up against our various project teams and the clinicians on those teams, and they told us things that were missing and things that maybe didn't belong, mostly the former. And then we ran also by our steering committees in each jurisdiction to make sure we had a fairly exhaustive list. And then on the supply side of things, we wanted to estimate the prevalence of competency to perform each of those services. And when I say competency, I'm referring to the combination of knowledge, skills, and judgment that are required to perform each of those services or provide each of those services to a senior in each of these jurisdictions. And that was done using combined web and paper-based survey for health workers in both jurisdictions, and I'll talk about that in a moment. So then once we had all of that data on the services that were needed and the services that were available, we compared the two of them and service-based plan, which I'll walk through. And once we had those gaps, we got some folks together in both provinces or both jurisdictions to talk about, well, these are what we found. First of all, does this make sense? Bring true differences in providing care or receiving care? So what can be done to address these gaps? An important part of that process was another process that we undertook, which was to, once we identified all the different services that were required in each jurisdiction, we compared that against the respective legal and regulatory frameworks for different professions in both jurisdictions to basically find out, so these are the services that could be needed by seniors, which professional groups are allowed or are not allowed specifically to perform each of those, so that when we tried to come up with different policy options, we didn't inadvertently suggest something that was illegal, or that was in conflict with scope of practice rules and those kinds of things. So this is a graphic representation of the service-based planning framework. Some of you will have maybe seen this before in some of our publications. Basically on the left side, you have determinants of supply of healthcare services, and on the right side you have determinants of your supply, and on the left side determinants of requirements of healthcare services. So starting with your stock of providers or people that you have healthcare, then wanting to build from there, accounting for what we call participation rates. So the proportion of people who license. So Gail, for example, is licensed as a registered nurse, but she doesn't actually practice in that capacity. So those kinds of things you want to account for in estimating the supply of healthcare providers and healthcare services in your jurisdiction. Also want to account for what we call activity rates, and basically that's just the amount of hours that people work. Some people work part-time, full-time, sometimes more than full-time, and you want to account for that if you can. The competency prevalence, as I alluded to before, is basically the proportion of your workforce that has the competency to provide each of the given plans to deliver. that's just the rate at which you reasonably expect a healthcare provider to deliver a specific service. If you multiply all those through, you'll get the amount that each service can be provided over some length of time. And you compare that against the other side, and that's the requirements. So starting with the population size, age and sex distribution within that, the incidence or prevalence of conditions within that population, people are sick for, we call the level of service. So given that, what are the number and type package of services that you want to make available or plan to make available for them to address that specific condition? So if you multiply those three things through, you get a number of services that are required to meet a given set of healthcare needs within a given population. If you compare those quantities, you'll find usually those numbers don't match. And I'll get to what we do there in just a moment. And the service gap can be used to inform or to quantify or examine your HHR gap. That's we think is part of the value of that approach. So a bit about what we found. So first of all, what are the big the top 5 conditions that are facing these two populations, Nova Scotia and Nunavut? As you see, there's some overlap in terms of the leading conditions in the two jurisdictions. Arthritis is common to both, diabetes and hypertension. But some differences, cognitive impairment and frailty, much bigger issues in Nova Scotia than in Nunavut, where cancer, respiratory, those are very much related, we think, to just the differences in the population. Nova Scotia is much older than Nunavut. There's a full generation, I think, in the average age difference between the two of them. And smoking is much bigger in Nunavut than it is here in Nova Scotia, certainly amongst the older folks. So once we'd identified pardon me, those as the leading health conditions in the jurisdictions, we set about the process of this great big list of all of the different healthcare services that could potentially be required. We ended up with over close to 200 different services. But what we found was, once we did the list for one condition, and then we started to add for another condition, we sort of reached a saturation point. And what we found too was that 80% of the services that you might need to make available for one condition would also be required for any of the other conditions on the list. So that simplified things a little bit for us. We customized those lists for the two jurisdictions, and some of the key differences that come to mind are, for example, in Nova Scotia, a big concern with our senior population is assessing ability to drive, and at what point do you have the conversation about that's not cars. Two, there aren't very many roads, and even if there were, I mean, you can't drive from any one community to any other community in Nunavut. So the whole driving thing is not nearly as much of an issue. Similarly, oral health care is not nearly as much of a concern up there. Not that the healthcare providers aren't able or wishing to provide that service, but the elders in Nunavut tend not to. They don't want that. It's just not it's a cultural thing. It's just not something that they consider to be. You don't do that. You just leave your mouth alone. So differences in the jurisdictions. So this is an example of what I was talking about. So this is just a small piece of our table of services, our competencies and conditions. So across the top of the conditions, and then down the side, going down into the depths are the different services that might be required, and the dots indicate services or conditions for which a particular service might be required. And as I said, there's quite a bit of overlap. So this is just to give you a sense of that mapping exercise. So then figuring out, okay, so these are all, that's fine, but how often should we be providing, or how often are those services really needed by our elderly? So those were, we came up with initial estimates from interdisciplinary panels or interprofessional panels of clinicians in both jurisdictions, which were then validated by the steering committees of both jurisdictions. We came up with a few different ones because, shockingly, we couldn't get all of the different health providers to agree on how often a particular service should be provided for a particular condition. I don't know if anybody else has ever run into that challenge. So what we did was come up with a few different scenarios that at least so that everybody could agree on at least one of those scenarios, and then we tested those to see what the differences were. Difference in terms of what the big gaps that were coming out were. On the supply side, we did a survey of, as I said, the health workers in home and long-term care in both jurisdictions to estimate what proportion of them were actually able to provide those services. And we used a scale that has multiple definitions of competence. So it wasn't just, do you feel competent to do this, yes or no? It was, there were 5 different responses from, I've never been trained to do this, I just don't know how to do it. I used to be able to do this, but I can't anymore. It's been too long, or what have you. I could probably do it if somebody would show me or would supervise me. I can do it on my own, full stop, and not only can I do it, but I can teach other people how to do it. So we were able to use, with those different levels, you can look at different levels of competence and what those might mean for your potential shortages. So what did we find in Nunavut? Not a large workforce in Nunavut, not a large population. We got 22 surveys back, and the sample size there says 22 plus, and that was because we found out after the fact that some of the home support workers had filled them out together. And we didn't know how many people, they were meant to be individual, but we didn't know how many people each of the surveys we got back actually represented. So it was a mix of regulated, non-regulated professions that did reflect the whole range of professions that are dedicated to those 2 sectors in that jurisdiction. So of course they have different designations, different terms for some of their professional groups than we do here in Nova Scotia. What were the big gaps in terms of the shortage, the services that don't seem to be sufficiently available? Different types of client assessments. So figuring out where is my client in terms of their particular needs related to mental health, related to the risk for falling, their environmental home, for example, and their own safety perhaps as a potential danger to themselves or plenty of ability to implement plans of care, or to respond to directions or carry out instructions, but in terms of doing the initial assessments, those were for Nunavut. Pharmacy is a big issue there. Dispensing, mainly because there is only one pharmacy for these. It's not an issue that we have here in Nova Scotia. But also the competency related to monitoring the effectiveness of medications and addressing any adverse reactions that come up. Polypharmacy issues, a big problem up there as well as here, which I'll get to. Getting clients and their families to understand what the health conditions are, what the treatment is, getting them involved in care, setting goals, working toward health promotion, those kinds of things are challenges for communities. Seems to be a gap or a service that isn't available as much as they would like. Nova Scotia, a bigger sample, but still not nearly as big as we would have hoped. We sampled 6 long-term care organizations as well as the entire Victorian Order of Nurses. So that still is only about a 20% response rate, which is, again, not nearly as much as we would like. That said, it was a pretty good split between regulated and non-regulated. Reflected the professions that do the bulk of make up the bulk of the dedicated workforces in those 2 sectors: CCAs, RPNs, LPNs, home support, and personal support workers, and others as well. So, looking at what were the shortages, pardon me, in Nova Scotia, we see some of them are the same in terms of ongoing client assessments. Mobility is another assessment that isn't as common or isn't as available as we'd like. That wasn't an issue in Nunavut. We think mainly because of the sheer difference in age structure. The seniors in Nunavut just aren't nearly as old as the seniors in Nova Scotia, on average. This is the biggest gap for Nova Scotia was what we called functional and social support. So things like personal care, providing socialization, helping people with activities of daily living, those kinds of things. Those were the single biggest gaps or gap area for Nova Scotia, not present in Nunavut for a number of reasons. One is a cultural thing. Just the role of the family is much greater. People, almost all of the seniors that are up there live with the family. They all live in the same place, so it's much easier for the burden of for care sharing to happen, and for the things to be distributed across the family, across the community. Everybody knows each other, so it's a community sort of response to that just is much more difficult to achieve in a place like Nova Scotia. Pharmacy issues, again, monitoring for effectiveness and adverse reactions. Polypharmacy, a huge problem. And similar challenges around getting clients and family to understand what the health problems are, how to do health promotion, how to be part of the process. So we presented those findings to the steering committees in both jurisdictions and said, first of all, do these make sense? Is this actually what you're seeing out there? Those were the gaps that came out. As I mentioned, we did a few different scenarios in terms of what services should be offered and how often, and those gaps came out consistently. The steering committees told us that yes, this does actually make sense with what we're seeing. So then we said, well, what could be done? How does this get fixed? And these aren't in any particular order. The responses we got is needing to have better coordination between acute care and long-term care and home care. People go into hospital for an acute episode, and then they come back to the long-term care home, or they come back home, and nobody knows what happened to them while they were there. They've got new meds. Nobody knows what those are about. Those kinds of things. We need more focus on providing supports in the community and in their homes for people to stay home and stay healthy. In Nova Scotia, for example, a lot of the biggest gaps are not things that require a lot of training. They're very practical things of helping people to just live in their homes along with villages. There seems to be a bit of concern about over-professionalization, making care for people more complicated than it has to be. People think there could be more focus on generalist roles. There's a need, particularly in Nunavut, but also in Nova Scotia, to better recruit and retain healthcare providers in rural areas. Strategies to reduce polypharmacy. We heard about this again and again. Electronic health records are helping to address this a lot in Nunavut, and there's potential for that to work in Nova Scotia, but it's much more complicated with a much bigger province, many more different private practices and those kinds of things. In general, more dialogue between health and education about what are the competencies needed of graduates coming out of the programs. I talked about some of the limitations, smaller sample size than we would have liked, multiple respondent issues. We didn't have some key professions represented in some of the responses, mainly because they're not dedicated working in those professions like physicians and pharmacists. So that's where we might be, just because we may be overestimating some of the gaps. But in conclusion, we think this is a good start.